Mr. Thompson survived his anterior STEMI in Part 1. We got him through cardiogenic shock in Part 2. Then, on day 3, the alarms trigger. The nurse calls you to the bedside. His blood pressure is dropping again, and there is a new, harsh, hollow systolic murmur. A new murmur appearing post-MI is a surgical emergency until proven otherwise. On the wards and on the USMLE, the common reflex is to guess papillary muscle rupture. Students hear new murmur and jump to the mitral valve without analyzing the specific acoustic qualities. Post-MI mechanical collapse is never random. The precise timing and the acoustic signature tell us exactly which cardiac structure has died. This diagram shows the post-MI mechanical complications timeline. We use the PMV framework to categorize them. The peak risk window for all three strikes between days 3 and 5. The P stands for papillary muscle rupture. It typically occurs between days 2 to 7. Depending on the infarct territory, RCA or LAD, the muscle dies, producing a hollow systolic murmur at the apex that radiates to the axilla. Think of the papillary muscle as the string holding a door closed against the wind. When that string snaps, the door swings open freely. The result is severe acute mitral regurgitation. The M stands for myocardial free wall rupture. This peaks between days 1 and 5. It is highly lethal, but it presents as a silent catastrophe. The necrotic outer wall crumbles, blood fills the pericardium, and the patient develops Beck's triad: hypotension, muffled heart sounds, and jugular venous distension, with absolutely no murmur. Papillary rupture is acoustically loud. Free wall rupture is completely silent, yet both destroy forward cardiac output immediately. Finally, the V stands for ventricular septal defect, or VSD. Like the others, it strikes right in that day 3 to 5 window. Its acoustic profile is distinct. A VSD produces a harsh, holosystolic murmur located at the left sternal border, often radiating to the right. The mechanism is literal. A hole is punched through the structural wall separating the two ventricles. Blood takes a high-pressure shortcut. This defect links specifically to anterior infarctions involving the LAD or inferior infarctions involving the RCA. The exact anatomical location of the murmur tells you which of these 3 mechanical disasters you are facing. When a patient crashes post-MI, auscultation is your primary diagnostic tool. Let's look at Mr. Thompson's data. The nurse explicitly localized his harsh holosystolic murmur to the left sternal border. It is not at the apex. We use the ALMA mnemonic for rapid exam differentiation. A is for apex, which equals mitral regurgitation. L is for left sternal border, which equals VSD. Applying the ALMA rule directly to Thompson solves the case. His left sternal border murmur mathematically rules out papillary rupture and points strictly to a VSD. An immediate echocardiogram confirms it. He has a 1.2 centimeter defect in the interventricular septum, and color Doppler reveals active left-to-right shunting. If you fail to localize the murmur accurately, you make the wrong diagnosis, and you send the patient for the wrong surgical intervention. Here is why that defect formed. Thompson's LAD infarction caused necrosis of the interventricular septum. Without blood flow, that normally firm muscle turns into soft, easily rupturable tissue. The mechanical stress simply blows a hole through the dead myocardium. This creates an immediate pressure gradient crisis. Blood aggressively shunts away from the high-pressure left ventricle directly into the low-pressure right ventricle. The left heart loses systemic blood volume. Forward cardiac output plummets, rapidly inducing cardiogenic shock. Simultaneously, the right heart receives that extra blood and becomes rapidly volume overloaded. This forces right heart failure, driving elevated jugular venous distension and peripheral edema. We quantify this severity using the QP to QS ratio, which is a metric that measures pulmonary blood flow against systemic blood flow. A ratio greater than 1.5 indicates a highly dangerous left-to-right shunt. The VSD creates a vicious cycle of biventricular failure. As the right heart fails under the extra volume, the shunting progressively worsens. When the physical exam is ambiguous, we use Swan-Ganz catheterization to differentiate MR from VSD. A Swan-Ganz is a pulmonary artery catheter deployed directly into the heart to measure internal cardiac pressures. On a baseline pressure reading, both papillary rupture and VSD will display a severely elevated pulmonary capillary wedge pressure, or PCWP. This table compares the Swan-Ganz readouts for both conditions. Notice the identical elevated PCWP values. Papillary rupture presents prominent V waves on the tracing, but crucially, it shows no oxygen step-up between the right-sided chambers. The VSD signature is entirely different. Because fully oxygenated blood crosses the septum into the right side, there is a measurable spike, or step-up, in oxygen saturation as blood moves from the right atrium to the right ventricle. The strict clinical threshold is a difference of greater than 7%. An O2 saturation jump of more than 7% between the right atrium and right ventricle definitively confirms a VSD. The anchoring mnemonic for the wards and the boards is O2 step-up equals step-right equals VSD. The echocardiogram visualizes the physical whole, but that greater than 7% step-up mathematically proves the severity of the shortcut. Survival prior to surgery requires an immediate stabilization protocol. The primary goal is to reduce left ventricular afterload, which minimizes the pressure gradient forcing blood across the shunt. We use nitroprusside as the primary pharmacological intervention. By reducing afterload, it effectively decreases the volume of the left to right shunt. Mechanically, we deploy an intra-aortic balloon pump to reduce systolic pressure and ease the shunt, while adding Dobutamine to support the ongoing cardiogenic shock. There is one absolute contraindication. You must avoid vasoconstrictors. They will increase afterload and fatally worsen the shunt. Medical management is merely a bridge. The untreated mortality rate for a post-MI VSD is 90%. Surgical or percutaneous repair is the definitive gold standard. The core exam takeaway is clear. Surgery is the only cure. The clinical question is simply when to operate, not if. Before we finish, let's review the high-yield exam traps. First, always localize the murmur using the ALMA rule before diagnosing any post-MI hollow systolic sound. This prevents the blind papillary reflex. Second, sudden cardiovascular collapse presenting with Beck's triad and absolutely no murmur points strictly to free wall rupture, not a VSD. Third, vascular anatomy dictates vulnerability. The posterior papillary muscle has only one blood supply, the right coronary artery, making it susceptible to rupture. By contrast, the anterior papillary muscle is ischemia-resistant, receiving dual perfusion from the LAD and circumflex artery. Finally, the temporal trap. Dressler syndrome causes a pericardial friction rub weeks after the infarction. It is an impossible diagnosis for a harsh hollow systolic murmur appearing on day 3. Mr. Thompson was rushed to the OR. The surgical team successfully repaired the ventricular septal defect. He survived again, but his story isn't over. Check back for part 4, when Mr. Thompson reaches week 6 post-MI and develops pleuritic chest pain. Subscribe to our channel to see what happens next.